Hello, Dr. Markle here of Centeno-Schultz Clinic. Today we're talking about the glenohumeral joint, also known as your shoulder joint. I'll be talking about specific conditions such as rotator cuff tears, instability, labral tears, and subsequent talks, but today we're doing a general overview of the glenohumeral joint. So if we're looking at the basic anatomy of the glenohumeral joint, you have a scapula, and then the humeral head or the humerus. They meet together to form the glenohumeral joint. It is connected via the AC joint to your central or your spinal canal or spinal column via your acromioclavicular joint. And then that goes all the way to your sternum to your sternoclavicular joint. So it's a rare joint in the fact that it's the only joint that's held on and attached to your axial skeleton via a small bone, such as that sternoclavicular joint. It's a very hypermobile joint. And because it's hypermobile, it's described as a golf ball and a golf tee. That golf ball is very hypermobile, where it's allowed multiple degrees of range of motion that allows you to do all your basic activities, overhead activities, throwing sports, racket sports, and all the dynamic motions. Now, to add depth to the glenohumeral joint, that golf tee, you see that blue lip, it's called your labrum. That adds depth. It's a fibrocartilage structure similar to your labrum in your hip or a meniscus in your knee that provides cushion and more stability. So further go on that lines of stability, the ball and socket joint are held together by a network of ligaments circumferentially around the glenohumeral joint. These are such as your superior glenohumeral ligament, your coracohumeral ligament, your medial glenohumeral ligament, inferior glenohumeral ligament, and then on the back side you have your posterior capsule. All of it envelops that golf ball to keep it directly on the golf tee to provide the stability for the joint itself. Then when we look a little bit more, you have muscles, your rotator cuff, that also go on top of that capsule to allow that shoulder to become more stable, as well as continue to move the shoulder. And up front, you have on top, you have your supraspinatus. You can see it from the back or the front. In the very front portion or the back, continue to the back, you have your infraspinatus and your teres minor. So the back portion is here to the right. And then the front, you have your subscapularis. Now, these four muscles make up your rotator cuff. Commonly, your supraspinatus is the most commonly torn. Behind that is your infraspinatus and your subscapularis. So shoulder instability is a very crucial and important concept to understand, because this is one of the underlying issues that lead to the vast majority of shoulder pathologies. So instability just means that golf ball is not being held directly on the golf tee very well, and it's sort of wobbling a little bit. And then if it wobbles too much, then it can start damaging other structures around the shoulder, such as your labrum, your rotator cuff, as well as the cartilage itself. So if instability isn't really identified long-term wise, it can create symptoms such as crepitus, clicking, popping. You could have excess range of motion, so too much range of motion, or it can actually cause less range of motion. Mechanical symptoms such as catching, locking, as well as in certain positions, the shoulder itself can just give out on you and you have decreased strength. And potential long-term consequences of glenohumeral joint instability is, well, the shoulder could dislocate completely, creating damage to both the ball and socket joint. And those are called Hill-Sachs and Bankart lesions. That excessive wear and tear can create osteoarthritis. It can put extra stress on the rotator cuff as well, putting some tears and extra strain on them. And that lip around the glenoid, that labrum, can also get damaged, which can create frozen shoulders and lost range of motion overall. But diagnosing a painful shoulder is a very critical, important aspects of just figuring out what's causing the shoulder pain. So having your physician do a detailed history about how it started, what causes it, and then what have they done for it, in addition to thorough examination. Now, that examination includes evaluating both the cervical spine, as well as the elbow and wrist examination to see biomechanically if things aren't working properly, or if nerves aren't working properly, they can also lead to shoulder pain itself. So the pain may not be even coming from the shoulder, could be coming from your cervical spine. So you need a very detailed examination to more differentiate where the exact problem is. And then doing a diagnostic ultrasound, we're able to evaluate in real time your rotator cuff, your labrum, and dynamically stress the joint to basically evaluate that overall stability. The reason why you need a detailed examination, because if we look at research, asymptomatic rotator cuff tears in the general population, so meaning people that have rotator cuff tears don't know about it and have zero symptoms, are pretty rampant. So if we look, almost 65% of the population over the age of probably 40 have rotator cuff tears and are asymptomatic. So rotator cuffs themselves are somewhat of a normal variant in your shoulder. So that's why the detailed examination is really crucial, trying to figure out, is that rotator cuff really causing the pain, or is it coming from somewhere else? And if we look at the labrums as well, same aspect for labrum tears. So if we look at throwing athletes around the country, there's a high percentage of them. This study looked at 2 different subsets of individuals, old and young. Almost half to 2/3 of the patients out there have labral tears, don't even know it. So again, it's a normal variant we see. So it's not just because you have one doesn't necessarily mean the pain is coming from the labrum. So for all shoulder conditions, seeing a good physical therapist is always a good place to start. They can improve the way the shoulder moves, the neuromuscular control, the coordination of the muscles around the shoulder, strengthening your rotator cuffs, make sure it's as stable as possible. There's more newer techniques such as blood flow restriction, electrical stimulation, as well as some other corrective exercises to help make sure the shoulder is moving the way it should. Posture is always a big thing. And then any myofascial adhesions, scar tissue, or what have you, they can help release. So physical therapy is always an excellent place to start that can overcome some of those injuries. Like I said, if you have a rotator cuff tear, labral tear, sometimes therapy is all you need to do. And then a lot of physicians now, if you go to physical therapy, still continue to have pain, they'll basically give you a corticosteroid injection. Now, I'll caution you just because steroids themselves can actually weaken tendons. They inhibit the collagen formation directly into the tendon and soft tissues. So long-term wise, that means it can actually cause your tendons to rupture or that tear to become bigger. Even if it wasn't symptomatic, that can actually become symptomatic. And then long-term wise, the cartilage of your shoulder joint, that glenohumeral joint, could get worn down and excessively degenerated because of the steroid injections. There's lots of research out here. I provide a couple citations if you want to take a look at some of those articles. And stay tuned over the next several lecture series. We're going to go through specific conditions such as rotator cuff tears, instability, labral tears, calcific tendons, as well as osteoarthritis, and how orthobiologics and some of those regenerative treatments could potentially help those conditions. So thank you very much. And if you have any questions, feel free to reach out to us on any of our social media outlets, our website, or give us a call. Have a good day.